Thank you for your invitation and for your patience to the late hour. Yes, we come from Poland, from a small private clinic, Satellite Medical Center, devoted to the conservative treatment of musculo-skeletal injuries and disorders, especially for spinal disorders. And our staff is rehabilitation specialists, osteopaths, and orthopedists. And we deal several years with the collagen injections. And we performed the comparative study in the region of lumbar spine in low back pain to pose the question, does the route of administration really matter? The rationale for this study was the fact that the low back pain is a very complex process. We all know the pain generators, conduction pathways, and disturbed pain signal processing, and peripheral and central sensitization. And you can see that the most involved structure with pain generation and conduction pathways are very close to the spinal segment. We all know the recurrence branch of the spinal nerve. We all know the medial branch for facet joints and the peripheral innervation on the intervertebral disc. And the experience of the pain medicine lead us to so-called linear thinking. The precision of access to pain generator and the dosage is a condition of the effectiveness of the treatment that determines the length of the therapeutic effect. So this is clear. The close to the region of the interest, to the region of the pain generator, the stronger is effect. But should this same rule apply to the collagen? We are thinking about our daily basis experience. Everyday experiences show us some patients with spectacular improvement even after subcutaneous administration in the lumbar area, and disappearing far from the main pain generators. And even if in the very advanced degenerative process, like foraminal stenosis, in addition to reduction of the pain, they also report functional improvement. They regain straight posture, increased flexibility, and general mobility. So this suggests that collagen may not be an ordinary drug that works on a complementary basis, like steroids, like local anesthetics, with a specific receptor and produce the therapeutic effect proportional to the dose and to the local availability, but rather is a biological active substance that triggers a cascade of repair process and not just a substrate, as we used to think very often. This is a part of our discussion during the morning hours. If so, its effect need not necessarily depend on the route administration, and that was the reason that we decided to explore how to change the effect in these three ways of administration. And our material and method, it was pilot study, randomized, open, single-center study. We had 30 patients with lumbar spinal stenosis, which were qualified to the study in a randomized way to 3 injections group. Group A, subcutaneous injections, paravertebral, in the line of facet joints. Group B, periradicular injections under ultrasound guidance. Group C, interlaminar epidural injection under ultrasound guidance. We used a mixture of 2 doses of MD neural and 1 dose of MD lumbar. It comes from our previous experience. It was the total doses per one session, and frequency of injection was 1 per week, totally 4 injections. And endpoint was WO before therapy, W1 end of therapy, so 4 weeks, and W2 after 1 month of follow-up. The control tools were visual analog scale, Oswestry questionnaire, Leitinen questionnaire, and functional test, one leg stance test. It means that patient is asked to stand on the affected limb, and we measure the time to occurrence of the pain. And the reference value was assigned as 30 seconds. Assessment of the treatment was done in mean values and minimal important difference. As a minimal important difference values was we accepted 3 points in the VAS scale, 10 points in the Oswestry scale, 4 points in the Leitinen scale, and OLST test it was equal to or more than 30 seconds. And criteria, inclusion criteria, it was adult patients, positive clinical test for foraminal stenosis. It is simply side bending to the posterior, lateral posterior quadrant, which provoked the pain axially and radiating down the leg. Lumbar spondylosis with foraminal stenosis confirmed by X-ray or MRI. You can see the foraminal stenosis in the level of L4, L5, L5S1, and it is the typical picture of one of our patients. Exclusion criteria, it was systemic disease, inflammatory, infectious, neoplastic, injuries, surgery, and neurological deficits. The technique of subcutaneous injections, we all know, it were multi-pointed injections, about half cc on the point in the line of facet joints, starting from the sacroiliac depression, sacroiliac joint, and in part of our patients it was done bilaterally. The technique is very simple, and everything you should care is not to pierce your own fingers. But more demanding is periradicular injection. You should use the ultrasound guidance, and first of all you define the desirable level, and then you go to the lateral aspect of the lamina and facet joints, and you spread the injectate as much as possible a cephalic way. It is a combination of transforaminal access. Even more demanding is epidural injections, but it can be done safely with the usage of ultrasound. The first stage is to assign the desirable level, then goes the needle to be in a contact with the lamina, then goes the local anesthetic before you pierce the ligamentum flavum, and then, as usually in a technique of anesthesiologists to lose resistance, you may injectate the solution. And you can see the dura, dark, bright reflection of the dura and lamina and thecal sac is very good, accessible in the ultrasound, and in the other picture you can see the very ending of the needle, which is penetrating the ligamentum flavum. So there was the technical issue, and this is a characteristic of our study group. 30 patients, 3 groups, majority of women, average age 62, but in the group C, you can see epidural group is a little bit younger. A duration of complaints average 11 weeks, but there is a difference in the C group. The duration is much longer. The range of duration was very huge, from 1 week to 1 year. Period of disease, majority of acute cases, the level of foraminal stenosis, most popular L4, L5, L5S1, and the side of complaints, both sides were in majority. All patients completed the treatment, but 1 patient from group A, from subcutaneous group, was operated between W1 and ending of the therapy and W2 follow-up visit, and was not included to the data of W2. And these are our results. The results are striking to us. The eye-catching story is the subcutaneous group is the only one which preserved the reduction of the pain in the follow-up. You can see red bar, red bar. We start with the similar values. After the treatment, we have quite good reduction of the pain, and even after 1 month, further reduction occurs. Astonishing is that even in the deep penetration of the collagen, the periradicular and epidural group make step back in the follow-up visit. The next mean value was Oswestry questionnaire, and a similar story. We have red bar, very nice reduction of the score. I don't know, you remember the scoring of the Oswestry, it is from 0 to 15, and if we have about 25, it is a moderate disability. So we start with the moderate disability, we obtain good result, and after the follow-up, the periradicular group and epidural group is worsening, is regression of the score. The next tool was the Leitinen questionnaire. The Leitinen posed a question about the need of pharmacological support. Beyond the evaluation of the pain, there is a question about how often you should reach for the medication. And the red bar is still very active. It still preserve the reduction of the disability. And we still have peculiar regression in the periradicular group. When we take a look for the percentage of the patients achieving the minimal importance difference, it means 3 points in the VAS scale, 10 points in the Oswestry, 4 points in the Leitinen, and this reference was assessed for these patients as a minimal important difference. The majority of patients is in the epidural group, but other tools, Oswestry and Leitinen, still the leader is subcutaneous group. And when we evaluate the number of the patients without the standing test within the or beyond the 30 seconds, you can see this baseline bar in the subcutaneous group. It was 5 patients which suffered the pain during one leg standing test. And after treatment, there was no one. So all of them achieved the improvement to sustain the 30 seconds standing and pressure on the foraminal stenosis. This is a striking result. And in the other groups, in the periradicular group and in the epidural group, there are still 2 patients left without achieving the reference values. And the complication in the study, we have 1 patient with the transient exacerbation of the pain during treatment, but without necessity to terminate therapy. It was in the subcutaneous group, no complication in the B group, and 2 mild punctation syndrome with transient and mild headaches in the epidural group. And these are our conclusions. Collagen administered by injection show a high safety profile. Regardless of the route of administration, paravertebral collagen injections exert an analgesic effect and functional improvement in patients with lumbar spondylosis in the short observation period. Subcutaneous injections seems to be of particular interest as a therapeutic option in such patients, showing no less analgesic effect and functional improvement than periradicular and epidural injections, with no risk associated with the technique of administration alone. Due to limited size of the study group, the obtained results should be treated as preliminary. They require confirmation in randomized clinical trials on a larger group of patients. Thank you for your attention.